I'm here to listen and to learn. I'm here to give you a broad overview of the history of the NCCP over the last 7 years and where it might go over the next 7 to 10 years. And I'm here to make a significant announcement, which has been alluded to earlier. Susan told me explicitly the first thing to do today is formally and publicly announce that this hospital is the lead centre for the management of these rare diseases. Jermone's been in place for a while, and I think over the next period of time we will see further development of this service, which will support and care for these patients. I know there are strong European links, we'll hear about that later in the morning, but it's important that in a country of this size, a population of this size, that rare tumours are managed really systematically. There's great coordination, patients know where to go, and that place to go is here. Don't ask me for details, don't ask me for funding commitments, whole-time equivalents, that'll all follow. So, the story of the cancer control program goes back to the middle of the last decade. At that point, the HSC didn't exist, the NCCP didn't exist, cancer surgery was done in every hospital. And what became obvious in the media and elsewhere, that hospitals that performed low volumes of cancer care, and these are all cancers, common or rare cancers, low volume activity led to poor outcomes. There were crises, disasters, tragedies in delayed diagnosis and treatment, well publicised in breast and colon cancer specifically. There was no coherence, there were no national policies on cancer services or standards, no agreed treatment guidelines, and there were no quality assurance programs. And this was actually a little bit strange when you look back, because what we have in this country in terms of healthcare professionals, the calibre of training and the people we have in posts around the country is above average. It's exceptional. We have a long tradition of excellent medical education for healthcare professionals, but we didn't have a system in which they could work to produce good outcomes for all patients. At that time, we had no coordination, we had no national plans for cancer screening, surgery, radiation, and medical oncology services, and a lot has changed since that point. The first major document, our foundation for cancer control, was the second national strategy document published in 2006, and that recommended a programmatic approach to cancer control. So that's what's happened. The government turned around and said, right, we have a cancer control program, and here's the mandate. So over the last 7 years, the focus has been on cancer prevention, screening, diagnosis, the treatment modalities of surgery, radiation, and medical oncology, hematology or hemato-oncology. And equally importantly, when you invest in services, you want to see what's happening. You want to know that there's quality. So you need quality assurance programs. You need to actually look at the rarer situations, not just rare diagnoses, but the whole broad area of hereditary cancer and oncofertility. And across the world over the last number of years, survivorship is a huge theme. So when you get a patient diagnosed and treated, what happens after they're treated? Survivorship issues, side effects of treatment in the long term, follow-up protocols, what's appropriate, what's not appropriate in terms of blood tests and scans. The challenges, apart from having to introduce a system and a program, was that we have a very good cancer registry. We know that cancer is getting more common over time, and therefore there'll be more demand for cancer services. However, at the same time, we have had 4, 5, 6 years of economic downturn and austerity, and all the other factors that affect every other part of our lives apply equally, if not more so, in healthcare. Fiscal restraints, a very simple but rather brutal moratorium on recruitment, and hopefully that is now lifting. And if the economy continues to pick up, we can actually invest wisely and in specific areas of cancer services to take some of the pressure off some of the services. On the upside, we have had a number of years of accelerated emergence of effective new cancer tests and treatments. These are excellent. They improve the outcomes significantly in a lot of areas, but actually because they're new, they have costs. So we are obliged to find those costs, and the NCCP advocates with government to fund the tests and the treatments that our patients require. Now, don't worry about the numbers here, just look at the bottom right. Over the next 3 decades, from 2010 to 2040, the number of cancer cases in this country will double. So that goes back to the previous slide. It just puts it fairly starkly. We know that the demand on our services will increase by that amount over that period of time, and we therefore are obliged to use that knowledge to plan a response. Going through some of the treatment and other services, we have screening programs. We've had breast check since 2007. This is the breast check centre here. We've had cervical check across the country since 2007 rolling out, and 2 years ago the more recent one is bowel screen for colorectal cancer. We have, and you'll all be aware of, over a period of time we have designated major hospitals as cancer centres: Cork, Galway University, Limerick, Waterford and 4 in Dublin. And the idea is that you concentrate your resources and your development plans on those centres. The initial phrase was centres of excellence, and now married to somebody who's not a cancer specialist, they feel a bit upset when the implication is our hospital, because they're not a centre of excellence, aren't good at other things. So I think centres of excellence may be a phrase that's past its useful dates, but we need to talk about cancer centres. So cancer patients should go to cancer centres. The big changes, obviously, we'll start with the common cancers, so breast cancer, lung cancer, prostate cancer, colorectal cancer. For those cancers, there's been sequential and quite radical restructuring of cancer services. Services and resources have moved, staff have moved. It hasn't always been easy, it hasn't always been welcome by the hospitals that felt they were losing resources, but it's in the interest of patients, so I think it was absolutely the right thing to do, and we will continue that direction as long as I'm director of the Cancer Control Programme. So breast cancer was the first group, and the principles apply equally to all tumour types. You want high quality services, high volume of activity, you want sustainable expert oncology services. We need to use local leadership, national leadership, we need collaboration between hospitals and now in hospital groups, and that just wasn't there in the past. As you will know, hospitals tend to compete with the nearest hospital for the same resources. That was self-defeating, it was destructive, and it's time for that to change. Since the start, the NCCP has had exceptionally strong political support from the Department of Health and the HSC, and it's important that we retain that strong position on the healthcare agenda. Outside of hospitals, there is a lot of work going on in developing referral pathways from primary care. You need to have primary care, secondary care, tertiary care, quaternary care, talking to each other. You cannot have separate groups doing different things without agreement. There has been a lot of development in simple stuff like electronic GP referrals, and that actually means that the patient's details get to the hospital in a matter of seconds. It is acknowledged by the hospital to the GP practice, dates are provided, etc. And because it's all electronic, it builds a database so it can actually assess the quality of the service. We are not struggling, but we're introducing a culture of key performance indicators. And what that basically means is every hospital reports its activity days, patient numbers, etc. The CEO gets a headache, but it has to be done. It gets reported for cancer, the KPIs. So how quickly did those patients get seen in clinic, and how quickly did they get their treatment? And that's an element of quality. It's unavoidable. It's in the early years painful to do it. It's potentially embarrassing, but people need to know how services are doing. If the KPI figures fall a little bit, you go in, you ask what's happening. They say, we have a problem with staff leaving, we have increased patient numbers, etc. And that's how services get improved, by addressing those problems that are revealed by KPI data. The NCCP runs annual audit quality and safety conferences. Yesterday we spent the entire day out in Farming. It was all about prostate cancer, and that's a program that's maturing nicely. It doesn't mean that the problems are solved. It doesn't mean that the service is perfect. It just means we know what we're doing. We meet once a year, everybody across the country who's in the area, to talk about the key issues, to talk about development projects, and to try and identify solutions to problems. For patients, we need to provide uniformly high quality, timely access to care, and care now is multidisciplinary care. It's not one patient, one doctor. It's one patient, many doctors, many nurses, many other health professionals, but that is a new process that is designed, and we know from other countries who started this years before we have, it is the way to get good outcomes. It is the way to use your resources best. And the final point on this slide comes back to the fact that we are actively engaged in manpower planning for staff, resources, facilities, technology, and we do a little bit every year. It is strategic. It is not blank checks to any hospital or any service, just saying we now prioritise this service over the next one, so the next year this project will get some funding, we'll move along. In terms of where we are with cancer surgery, don't worry about the details here, but just take the top line there. For breast cancer, by 2009-2010, we had eight rapid access clinics for symptomatic patients with breast symptoms, which may not be breast cancer. For most patients, aren't breast cancer, and there are 8 surgicals. Those patients have surgery in the same 8 hospitals, and the numbers change. As we go beyond this slide to the next phase of development, the less common tumours, those numbers of clinics, those numbers of designated sites for surgery will be less. So this is where we're going now. Neuroendocrine tumours, what we're talking about today, sarcoma, gynecology, upper GI, head and neck and melanoma, less common, equally difficult, equally complex diseases, and the focus is now on these. We have some background baseline documents which are HSC or HICWA authored, which we use. They contain the principles by which we operate, safer, better healthcare. I've talked about KPIs. We have a lot of work done over the last couple of years in developing national tumor group guidelines, and this is where you get all the clinicians, which frequently is all the clinicians in that area in the country, into a room. You get a research methodologist, and you get all the research information that's available, and you put it all together and say, right, what are the priority questions we have to answer? And over a 2-year period, you look at the evidence, you come out with a consensus document. So the Minister is going to launch tumor group guidelines for breast and prostate cancer in the coming months, and it reflects a lot of work, but it sets a standard for care, and it will be applicable from day one. Surgical oncology, just like every other area of manpower planning, it has its challenges. An area where I'm very comfortable, radiation oncology, that's what I've been doing for the last 17 years. Just to give you a few slides on what's happening there. St. Luke's Hospital has been in existence for over 70 years. In 2011 it became a network. With the assistance and full-time involvement of Kin McGrain, we actually opened 2 new centres, a capital cost of 60 to 70 million euros. So we now have a network of 3 centres in Dublin, 1 site in Beaumont Hospital, in St. James's Hospital, in St. Luke's North Scar. It's a network. The staff move between centres, the patients move between centres. It increased the number of treatment machines and treatment capacity by 50%. This network is probably now one of the largest networks in Western Europe. It has all the new technology. We provide a comprehensive service. We have an intracranial stereotactic radiotherapy service in the Beaumont Centre, because that's where the neurosurgery department is. Stereotactic radiotherapy is the highest level of complexity and sophistication of radiation treatment. It is useful for brain tumours, secondary deposits, etc. We have a similar program in St. James's Hospital, or the centre in St. James's, for extracranial stereotactic radiotherapy for small lung cancers where patients can't have surgery, and that's located there because they have a very large thoracic oncology program. We have prostate brachytherapy, and what that is for early stage low risk prostate cancer, men can have a number of different treatment options. One option is where you do a stay case procedure. You put 80 to 100 small radioactive pellets in the prostate gland. They deliver radiation treatment and cure the prostate cancer with excellent long-term results. For many years, Professor Frank Sullivan Galway provided the entire public service in the country. Under his leadership, we have now opened that in Dublin and Galway, Dublin and Cork. So that's clear progress, and I'm very happy to see it happening. What we're currently working on is Cork and Galway. There are big construction projects going on there. The new centres for radiation oncology will open there in 2017, 2018. We are going to reach capacity again in Dublin over the next year or 2, and the Minister has approved 2 extra treatment machines in St. Luke's and Rathgar next year, and then beyond that. So with radiation oncology, just like every other area of oncology, you don't want to be in a situation of deficit where your patients are coming at night time for treatment. You want to be able to treat them 9 to 5 or 8 to 6 or whatever. You need to be able to do it and plan for the future. So once we've done all this investment, we will then have a rolling replacement program for all the treatment machines. One very exciting opportunity or development is the new cross-border initiative or project in Altnagalvin. So Derry, London, Derry, they're putting in radiation machines to treat patients, and we're not partnering, but we're participating in that in terms of capital and revenue funding. So for patients in Donegal and the Northwest, they from 2016 will be able to have their treatment as outpatients at Altnagalvin rather than spending a week in Dublin away from their families and friends. Other areas that have been progressed over the last couple of years in medical oncology, the medical oncology drug budget is massive. And until the NCP came along, it was not particularly well coordinated. We now have drug protocols. We now have a drug management program. We now have a technology review program, so new drugs that come along. If the research is looking good and the vendors are saying it's a great drug, we actually have a formal appraisal process for that, which means that we make appropriate recommendations to government for funding for new drugs. It's not designed to slow down access, it's meant to accelerate access, but do it in a rational way. We have a big project coming up, it's an IT project, Medical Oncology Clinical Information System, where we have electronic prescribing, we have good data accumulation and wise use of the data in supporting the services that exist and that will develop in the future. A safety review was carried out across all the centres delivering chemotherapy last year. Safety policies are in place. We're expanding to hematology in the same way. We've talked about KPIs, we have consent process for patients, and again, medical oncology is one of the most underserved, not underserved areas, but in terms of number of medical oncologists per head of population, we are well behind the European standards and North American standards, and that will become clear over the next year as we respond to that. Community oncology, and this is what I talked about earlier, outside of hospitals, what's happening. We talked about electronic referrals. We're now working on melanoma pathways. We have a national meeting on that coming up in the next week or so. We have community oncology nursing, and this supports primary care nurses in managing patients who have cancer but don't necessarily need to go to hospital. We have nurse training, electronic learning programs for both public health nurses and also hospital nurses who are working in non-cancer specialties. We have GP referral guidelines, and we work closely with the ICGP to help manage the referrals and identifying the patients who actually need to come either on an urgent basis or non-urgent basis to the nearest cancer centre. And so far we've completed work in breast cancer, prostate, lung melanoma, etc. Skin cancer is our second wave of development, and there is an educational program targeting primary care school children. You'll know about the legislation on sunbeds, etc., and this is all part of that. Survivorship, which I've mentioned, it's again post-treatment, it's follow-up care. There's a lot of debate about what is survivorship, and things that people agree on. Well, it's providing a patient with a written treatment summary, so when they go to another hospital, go back to the family doctor, they can show that person or that service what they've been through. It is about giving patients as much information as they want. It is about integrating primary and post-primary care, and it also is an opportunity to talk about a healthy lifestyle. You can cure a cancer, but if the person keeps smoking a pack a day, they may get another cancer. So there is things like tobacco dependence and smoking cessation, etc., cardiovascular disease. It's an opportunity to look at other problems the patient may have or lifestyle modifications they may wish to make. In terms of next steps in the cancer control program, a priority for 2015, and it's actually been accepted in the service plan for next year, is the appointment of a lead person in hereditary cancer. It's joint work with the National Centre for Medical Genetics in Crumlin. It's about improving access to counselling and testing where there's a family history of certain cancers. This person will not just be another clinician, they'll be a leader in the field, and I would say over the next 5 years, once a leader is appointed, there'll be further development in that area. In the last couple of months, we've had an evaluation panel in to look at how the NCCP has implemented the 2006 National Cancer Strategy. That panel contained a radiation oncologist, a professor of clinical nursing from Southampton, an expert in public health and screening, particularly from Rotterdam. They are drafting a report at the moment, which they will submit to the Department of Health shortly, and that will actually tell us where we are in terms of our strengths, weaknesses, and where we need to go next. We will continue to centralise cancer service into cancer centres. We, as I've mentioned twice already, will be looking at other cancers in addition to more common cancers, and we will continue with our QA programs. There's a live QA program across the public and private sectors in histopathology for cancer patients, radiology, endoscopy, and I'm very keen to roll out a QA program nationally in radiation oncology in 2015. Treatment guidelines, information technology, HR planning, and obviously that is the biggest challenge at the moment. And the final thing on the list here is outcomes research. How are the services performing? We know about the funding, we know about the HR, but actually what's the return on investment for the public? It's exchequer funding behind all of this. Are outcomes improving? We know from European data there is scope for Irish outcomes to improve, and now we're going to focus on national and international efforts to measure and to publish our outcomes. The next 10 years, what this really means is that we've come to the end of a second cancer strategy. We're going to launch a third national cancer strategy. That'll be a 2-year process of consultation with healthcare professions, with patient groups like yourselves, to figure out what do we need to do next. We know what the demands would be. We know where the cancer rates are going. We know that we have work to do in terms of staffing. We know it'll cost money. There is new technology apart from treatment, molecular diagnostics, personalized medicine, where a patient comes in and you don't give them the standard drug, you do a test on that patient and that tumour to find out which treatment they will respond to. And that is exciting 21st century medicine. I think clinicians are very keen to be completely involved in that. A theme with the hospital groups, talk to one or two of the chairmen of those groups, you need to have the universities and the hospitals and industry working together, sharing information, providing support. We need to move along with cancer prevention. It's great having better treatment, having better diagnosis, better treatment, and better outcomes, but actually prevention is better than having to treat the disease in the first place. And as I mentioned before, survivorship is huge. So that's all I'm going to say. Hopefully that gives you a good picture of where the cancer control program is, where it's come from, and what we're doing over the next couple of years.